I'd like to welcome everyone to the Health Pathways Mental Health in General Practice Day. Firstly and most importantly, I'd like to acknowledge the beautiful land that we're on. This event is being held in the traditional lands of the Ngunnawal people, and we pay our respects to their elders past, present and emerging. I wish to acknowledge and respect their continuing culture and the contribution they make to life in this city and region. I'd also like to acknowledge and welcome any Aboriginal or Torres Strait Islander people that are with us here today. I've got a couple of housekeeping tasks. The bathrooms are outside on either side of the staircase. If there's an emergency evacuation, it's outside in the banquet at the left. I hope everyone's signed in with their COVID check-in app, and we'd appreciate if you turned off your mobile phones, please. We have learning outcomes, which I'm not going to read out to you, but these are the learning outcomes for the event, and I'll give you a moment to read them. Oh, and I forgot. Hi, I'm Louise Kenyon. I work on the Health Pathways project at Capital Health Network. I'm also the advisor on their events program. So if you have any comments, suggestions, love to hear them on either of those programs. I work as a GP at Warramanga. This event is a CPD accredited event from the RACGP. If you have any problems with the event and want to give any feedback, you can go onto their website. There's also a hard copy form over in the back. Any feedback can be confidential. There have been no conflicts of interest disclosed by our presenters today. At the end, we're going to have 2 question and answer sessions. In the middle of the table, you've got booklets, and each of them has the presenter's name on the top. If you could, as a table, write down your questions as you go, we will collate them, and in the question and answer section, at the end of the 2 sessions, we'll ask them as a group. We'll have a panel set up here. Has everyone got them? Okay, we're going to move on to Tabitha, who is kindly going to speak to us today with the brief we've given the presenters is we really want to acknowledge the 15-minute time frame of GP. That quite often we're seeing people with these things, they're in extremis with their families, they've self-harmed, the eating disorders come to a head, it's a child being brought in by an adult, it's been fit into your day, and you're trying to deal with it with negative time. So we've got Tabitha, who is the clinical director and owner of Ascentium Clinical Psychology, and she also works with the Access team for many years, and has worked in the army. Very interesting. She's got a passion for a multidisciplinary approach to healthcare. Thank you.
Thank you, Louise, for the introduction, and good morning, everyone. It's lovely to be here this morning. My focus today is on complex patients. I thought to cover this topic because in my mind I imagine that all of us have had the experience where we work with a patient that we might classify as worried well or middle-aged and sad. And for those patients, often what we might do is work with them in a CBT model, and for yourselves potentially prescribing SSRI and talking about lifestyle factors. For these patients, we often see them get through that life transition issue, recover well, and go on to the next stage of their life well. So these are the patients that generally are quite easy for us to work with. Where the challenge comes for us often is those patients that present as a clinical puzzle. So these are the ones that often are difficult for us, they're challenging, and across the treatment continuum can end up being quite rewarding when we can support them towards wellness. These are the patients that I think often decompensate across the lifespan. They're the people that, independent of intelligence and of lifestyle factors and supports, these are people that across their lifespan often relapse into depressive and or anxiety-based episodes. It's been my observation as a psychologist that as GPs, you don't often ask enough of us in terms of us providing you with our psychosocial clinical case formulation. And I think as psychologists, we're often quite tender and introspective people, so we're not likely to reach out to you and provide that case formulation commonly. So with my presentation, I thought that I would like to bridge the gap by firstly speaking to you about what I think are the common assumptions within your GP consult, and then I would like to outline what we might do as a psychosocial case formulation so that you can see potentially what we have to offer to support your GP consult. All right, so to that end, the scope today, so I'll look at briefly what I think is a common GP mental health consult. We'll then look at some of the complex psychosocial maintaining factors for mood and anxiety disorders, and then I've collated a list of quick tips for your consult. So when it comes to what I think happens for you in a mental health consult, I imagine you've got 15 to 30 minutes with a patient, and a common presentation might be an adult female that comes in. She's reporting some low mood, fatigue, she's feeling a bit on edge and having difficulties sleeping. Otherwise, she's someone that doesn't present with a complex medical background. I assume that at that point then you'd complete an MSE, you'd look at doing a risk assessment, you might take a good medical history, look at current lifestyle factors, family history of mental health, administer some screening tools, maybe do some bloods, and then medicate if required and refer to psychologist or psychiatrist. In the consult, I'm assuming that what you don't have time to do is to reflect on the psychosocial factors that may contribute to that patient who, independent of receiving CBT and an SSRI, often doesn't get well. Would that be correct? That's generally a consult? Yep. Okay. So when it comes to what we do on our side that can, I guess, support your practice, we often would spend time with the patient mapping out the psychosocial factors that are maintaining the complex condition. So in my experience, mood and anxiety disorders that are protracted, where people get stuck and continue to decompensate, often the mood or anxiety disorder is kind of a second order effect of something else going on underneath. Firstly, I usually categorise the patient into 3 domains. So I look at, do they have a shame-based presentation? So for these types of conditions, often we would see patients that aren't likely to speak up unless we're asking the right questions. So this is where we might have an undiagnosed PTSD or complex PTSD. Often for these patients, they may not even know what a trauma event is. So if we ask them about trauma, they may not actually really see some of their experiences as fitting into that category. We then have those patients that are currently in an active family violence situation. And these are patients that will often come in and either present very well or present very closed. And often a lot of the symptoms that we're seeing are survival-based symptoms that they have in order to maintain, remaining in that relationship. And as clinicians, what we might do is pathologise those symptoms when really we need to give them an opportunity to get to safety before we would do any kind of diagnosis. We then have patients with gender identity issues, which is a common and emerging area of interest, and then patients with obsessional traits. So these are your body dysmorphia, your OCD, and a commonly underreported condition of hoarding disorder, which I believe we have a fair bit of in Canberra, but is often not spoken about and presents as anxiety. Second, I always look to see about the person's impulse control. So this can be either over-controlled or under-controlled. And here we're looking generally at your personality vulnerabilities. Often we look at cluster B because that's a fairly obvious presentation when we've got someone coming into the room who's very dysregulated. But potentially what's often missed are conditions like your schizoid and your obsessive compulsive PDs, and these are conditions that are way more inhibited and over-controlled. We then have patients who can, present quite well dressed, educated, and underlying can have problematic gaming behaviours where they're online from 6 p.m. to 4 a.m. Most days, gambling, and then also excessive pornography use, which is something that's emerging more and more now in our society. And then finally, another area that's emerging now is neurodivergent presentations. There's a lot of adults now becoming diagnosed with autism spectrum, ADHD, and these are conditions that often, if they're underlying it in the background and untreated, will often lead to the person presenting as being socially anxious and or quite depressed. So I thought I'd put together now a bunch of quick tips, just being aware of like the 15 to 30 minutes that you have with your patients. So obsessional traits. I think that Nishad may speak on this a bit later or provide a bit more information. But in the DSM at the back, there's the chapter on assessment, and in there's the DSM-5 cross-cutting administrative tool or assessment tool. It takes about 2 minutes to administer, and this tool taps into 13 domains of psychopathology. So if you have a patient that presents with more than a one episode depression or anxiety that's been across their lifespan, what we would want to do is, instead of doing the DAS or the K10, this is an equally plausible measure that you could administer to tap into these different domains. When we're looking at in the context of obsessional traits, if this person presents with anxiety, but underneath they actually have a hoarding disorder, for example, that's sort of the, the precipitating and the perpetuating problem in their life, we're often not going to pick up on this unless we really ask those targeted questions. So the cross-cutting measure will tap into repetitive thoughts and behaviours. And then from there, you can explore more about hoarding particularly. So when it comes to this condition, for anyone that presents with anxiety, I would certainly be asking, do you have trouble discarding things that most people would get rid of, or is part of your anxiety that there is challenges having people come to your house? So these are things that we can sort of ask around that topic. Then when it comes to OCD, so the cross-cutting measure will tap right into OCD. If you find the patient elevates on those two questions, then at that point there are other screening measures that you can administer, but really just asking a few good clinical questions around that topic area would probably be enough to give you the information that you need to action a referral. Then when it comes to body dysmorphia, so this is a condition again that can be quite complex. I believe Vivian Lewis might cover a little bit of this afternoon, but really here all we're seeking to know within the obsessive traits is whether the person is fixating on a certain part of body, for example their nose or their feet or hands, and whether that obsession is essentially impacting on their functioning, stopping them leaving home, having a sexual relationship, engaging socially. And then finally we have gender dysphoria, which again is emerging more and more now in our young population. Often with these patients, they will come forward and say that they're struggling with their gender identity, And I think part of the reason for that is we now have more social language around gender dysphoria, so we find that age group can advocate for themselves quite well. But just looking for yourselves, the difference is around not so much fixating on a neutral part of the body, but it's looking more at those sex characteristics. Right, so the next one is impulse control problems, so remembering over or under controlled. What I would usually do here is have a look again at the cross-cutting symptom measure. So here we're looking at the substance dependency or misuse questions. So anyone who meets threshold on that cross-cutting measure, it can be useful to explore briefly, firstly about trauma, and then about what we would say are second-order effects or coping strategies for untreated trauma, which often comes into your gambling, pornography, and excessive gaming behaviours. When we look at most people that struggle with gambling, for example, there's often an underlying anxiety disorder, and the gambling environment feels good for that person in terms of it helps settle their anxiety. So anyone that comes in with the substance abuse problems and or anxiety, we're often looking for these impulse control issues. And then when it comes to trauma, often, in our field, everything often leads back to trauma. But when we look at trauma in terms of what I would consider the criterion A events in DSM-5, so your sexual violation, threat to life, these types of traumas, often we see people misusing substances, whether that's prescription drugs or alcohol, essentially self-medicating. So how I would usually ask about that is not so much to ask technically about how much alcohol the person's drinking and to administer an audit or some kind of measure. What I would be looking to do is to just gently open up that topic and stating, words to the effect of sometimes when someone has experienced something difficult in their life, they may turn to alcohol to cope with the memories. So again, if someone meets the trauma threshold on the cross-cutting measure, as well as the substance use, that's an area that you would explore gently. Active family and domestic violence. So Professor Bao will talk a little bit later about interpersonal violence from the perspective of the perpetrator and a little bit about victim vulnerabilities, which is a controversial area. But for myself, I thought I would just cover off on a couple of quick tips for within the consult if there is, suspicion that there may be domestic violence happening. So I think that the first question that we need to ask is, do you feel unsafe because of anyone at home? So when we're looking at using the word unsafe, we're not shaming, we're not saying that a perpetrator of this type of violence is bad, we're not putting them down. That type of questioning or line of questioning can actually induce shame in the victim and prevent them from speaking up. So usually I would just start with that type of exploratory question, and what you're doing there is embedding a subtle permission for the patient in that they don't have to answer that question, but they know that down the track you might be a person that they can talk to about it. With the establishing permission, so if you do assess that it is happening at home, you can then move straight into looking at immediate safety planning, which can be something simple as, would you like me to support you to contact services such as DVCS or other advocacy services. So within your consult, you don't need to take, I think, a lot of time exploring what's going on there, but just looking at referring that patient in very quickly to those services. When it comes to their file, some patients don't want that information on their file and then others do. For some of them, I guess I would encourage to have notes on the file, particularly if within your practice they're going to be seeing different GPs when they come in for their general consults, and it just gives an alert to that GP around things like asking before touching for examination and really checking their mental state on that day as to whether they're able to engage fully in the consult. common issues that we might see that are risk factors for, I guess, homicide, suicide, killing of children. We might see a person who experiences a lot of dissociation, both the perpetrator and the victim. But in the victim-centric context, we want to be looking at obviously head injury, concussion, sexual assault, looking for strangulation as well. When it comes to documenting the injuries, I worked on a quite complex case recently with child protection where the main evidence that was used to remove the victim and the child from the family home covertly with the AFP was the medical notes. So we had encouraged the patient to go and see their doctor every time there was an incident. We set up that safe relationship, and when the patient presented, the GP did have to document the bruising, the evidence of the injuries, the patient's self-report, and while that can be a difficult thing to do, those notes were subpoenaed by Child Protection and used very swiftly to get the child out of the house. And then I guess my only word really with caution around this population is if we're looking at prescribing sedating medications, which you might often do if they're coming in agitated, just being mindful of how that sedation can impact at home. So if we have a perpetrator who's trying to keep them awake all night so that they're tired, and then they're taking sedating medication, that's obviously going to be a point of conflict within the relationship. And also even the perpetrator asking the purpose for that medication. It also, too, if we're combining it with periods of dissociation, we also have, I guess, that complex connection between dissociation and a sedated patient who may be caring for children as well. And then the other factor really is, I think for most of us, that a high on compassion. When we come across someone who is a victim of domestic violence, we really might want to be in that helping mode. And with these patients, they can often present as being in learned helplessness. That's part of it. But for us to race in and do lots for them, or tell them what to do, or help them make decisions for them, in that context, we're disempowering them. And finally, second last, so chronic self-harming. I didn't want to talk much about this today. I think just basically sort of more looking around the complex patients. We often, I think, categorise self-harming as being the young adolescent who's very pained and coming in and cutting themselves. But self-harming actually can be quite complex, as some of you may know. Personality disorder is not always the maintaining factor. Commonly it is, but not always. For these patients, I think we often need empathy and a multidisciplinary team around them. So when it comes to adolescents, we want to be exploring undiagnosed ADHD and ASD, or PTSD, such as active sexual abuse in the home, high correlation between sexual abuse and self-harming. And then we also want to look for first episode psychosis, family history of psychosis, and any illicit substance use. For older adults, often we see self-harming presenting as a result of chronic pain and social isolation. So when we have elderly patients going through their stage of life review, for some people, they look back on their life and their reflection is that their life hasn't been how they wanted it to be. They haven't lived in accordance with their values. Their relationships aren't fulfilling. They've maybe experienced a lot of trauma. And for these patients, there can be almost a treatment-resistant depression that we might only use ECT for. That might be the sort of final stage of treatment. And with these patients, we do often see that, the self-harming coming in as a way to sometimes end their life or to cope with the distress around those thoughts. And then The other one is, I guess, major self-mutilation, which we might not often see in general practice, but more in a hospital setting. People who burn themselves, set themselves on fire, people who try and amputate a limb. Often here we're looking at a somatic type delusion, or we're looking at a psychotic episode. So that's something where we want to be looking out for that. Sometimes people with a delusional disorder, they might present quite well in other ways. So we're just looking for that, potentially that somatic delusion. My arm's got this pain, I'm sick of feeling it, it's burdening me, and seeing, a limb as almost an enemy of the life. And that's where we look at, sometimes having the self-mutilation. And finally, looking at neurodivergence. So I think that more recently, as we've had the move with the NDIS and the, significant influx in young people being diagnosed with autism spectrum, we're now seeing a lot of adults who parent those children, recognising in themselves having some of the same symptoms. The reason why I put this one in is because I think living with untreated ADHD or ASD, for those that can mask really well, go off to work, engage with a few friends, but behind the scenes we see a lot of difficulties with managing tasks of daily living. We see the neurotypical spouse taking the mental load in the relationship and often doing most of the domestic tasks. And we also see, in some cases, domestic and family violence from people that don't actually have those beliefs around entitlement and around callousness, but actually just cannot regulate their own impulses and anger and have a very low frustration tolerance. So I think in this population it's very important that we're looking at referral to specialist and stimulant potentially as a prescription. So what I would usually do is looking at family history of ASD, ADHD. This includes undiagnosed when I'm doing a clinical interview. So if there's been an uncle or two that are quite quirky, dad's always been, locked away in his study researching, European wasps, we might find at that point that we've got some indicators of what's going on. We also see with this population across their medical history an accumulation of all kinds of diagnoses. So sometimes borderline personality disorder, which we might see when the person's having a meltdown in the practice room. That can be sort of quite scary and is very dysregulated. But what we're looking at there is a neurocognitive overwhelm. We're not looking at someone who, who's fearing abandonment or who's feeling, threat in the room. We often see eating disorders can be comorbid as well, and OCD can be another diagnosis that can potentially be comorbid or a differential. I would explore generally just a couple of key areas, so looking for fatigue after social interactions or interactions that involve a lot of emotional discussion or exposure to lots of sensory information. And then a couple of quick screens, the RAVES, and then there's the ADHD adult screen. So these take, again, about 1 minute to administer. They've got good validity, and I think establishing a couple of those key diagnostic criterion, administering the screen would be sufficient enough for referral to specialist and potential trial of a stimulant, depending on some other history factors. Okay. Thanks for listening.
Thank you, Tabitha. So if anyone's got any questions for Tabitha, we've each got a sheet on the tables, and we'll collect them and collate them for question time at the end of the session. We've had a change in our program, so very kindly, we've got Professor Bauer, who is a professor at the University of Canberra. His area of research is intimate partner violence. He's written many books, chapters, articles on the subject. He's got a history of working clinically in the correctional services. So please welcome Prof Bauer to us today.
Good morning. I'm going to be taking off my glasses so I can read my slides. So if you have a question, you have to wave. The area of intimate partner violence is one of a number of areas of interest to me. But when Tabitha was going over her slides with me, I thought maybe a focus. I've only got 15, 20 minutes. And normally I do workshops that take a day or two. So 15-minute quickie review of partner violence is going to be a bit of a practice run for me. Try and use the same sort of framework as Tabitha. So you have a practice consultation. What might it look like? What might be some of the issues? And how do you move forward? So you may have a male patient presenting for a consult. He's angry with his partner. He's agitated. He has a low mood, problems concentrating. He complains about his relationship and relationship stress. Has a penchant for substance abuse, and he drinks because of. You hear the word "because" an awful lot. I drink because she makes me angry. I drink because the kids make me. I'm angry because my boss doesn't like me, and so there's a lot of dysregulation in his life. You complete an MSE. You look at suicide risk assessment. Take a medical history. Look at that family history of mental health. A screening tool. You're looking at symptoms of anxiety, perhaps, maybe low mood, maybe depression, and then providing advice on maybe stress management, social engagement, and there might be some, I've been to numerous GPs over the years, probably one or two of you are here, asthmatic, so I'm always seeing the GPs for meds, but there just isn't time. I as a psychologist, we have sort of the benefit of 1 hour sessions, 1 hour, and you guys, I can't imagine doing the work you guys do. It just amazes me the number of clients or patients you can see, and you can't consider all the factors in a brief consultation. It's pretty amazing. The referrals I get from GPs are full of information. I'm always absolutely impressed at how much work you can fit into your sessions. Now, intimate partner violence, as I was talking to Dr. Sloan this morning, and you guys know this yourselves, this is a massive problem in Australia. I'm originally Canadian, and so I worked in Canada till I was almost 50, then in New Zealand for 7 years. Now I've been here for almost 10. And it's the same everywhere. Every one of these Commonwealth countries I've worked in, intimate partner violence is a massive problem. And about a third of women in Australia experience physical violence after the age of 15, a fifth sexual violence, maybe more, and a third has experienced physical and or sexual violence perpetrated by a man since the age of 15. So the most common forms of intimate partner violence include the physical, emotional, economic abuse by someone with whom that victim has an intimate or romantic relationship. So everybody who works in health, all healthcare professionals, psychologists, etc., we're all going to see, and I teach the forensic clinical unit at the University of Canberra in the Masters of Clinical Psychology. Generally, there's about a dozen, 15 students in there. Maybe 2 begin the unit thinking, I'd like to work in forensic. The others say, I don't want to borrow this stuff. It doesn't apply to me. I don't want to do this. And I ask, how many of you might do couples counseling someday? Well, you need to know the risk issues for intimate partner violence. It's going to present. And if you don't know what the risk issues are, you're not hearing the message, you're not seeing the signs, and you're not making referrals accordingly. So this is stuff everyone who works in health, either as a primary provider like yourselves or allied health professionals like psychologists, social workers, etc., needs to know the factors in intimate partner violence. So, already mentioned sexual and physical violence. A great deal of intimate partner violence. The legal framework downplays the sexual aspect, the sexual violence within these relationships. About half of intimate partner violence victims experience sexual violence at the hands of their partners. So that's really underdiagnosed and underestimated. And a lot of guys go to prison, if they go to prison, and take a domestic abuse program, which is 20 sessions, believe it or not, a 20-session program, and then they manage to get out of or not get charged with sexual violence or physical battery, and then the physical violence program is 90 sessions. So physical violence against a stranger is taken much more seriously than physical violence against a partner within our legal and treatment systems. But you know that. So this one came out weird when it was converted to a PDF. So psychosocial is one word, not two. So there's all sorts of complex psychosocial factors in intimate partner violence. A person might say, I've got real problems with anger management. I'm losing my temper at work, but he's probably losing his temper at home. And so there's ways to disguise the issues for perpetrators. Feeling jealous, possessive, suspicious, defensive. A woman may come in, a female partner may come in and say, my husband's really jealous, he's really possessive, and that's the way to sort of break the ice for her, perhaps, in talking about being a victim. Offenders tend to have low self-esteem, quite emotionally dependent. The world shrinks around them. Their partner becomes their world, and controlling her, I'm using the general case, that's how they function. Everything revolves around controlling what's happening in that home. Feeling inferior, insecure, believe they have the right to control their partner, including all the finances and social activities. Common disorders include things like ASPD or some sort of psychological disorder, being psychotic. So active psychosis is a real obvious problematic risk issue for violence generally, but also within relationships. So an emerging psychosis can be problematic. Often having violence modeled for you in your family of origin, where domestic violence was accepted perhaps, going back decades. And other forms of abuse within the family of origin, also drug and alcohol abuse. Impaired people are less likely to control their violent impulses. So drinking to essentially becomes a way to sort of become more agitated. So I'm trying to make up the time because Tabitha went over time. With my permission, I said that's fine because this is not the general presentation. I get that, but I also think there's just no way I can do a risk assessment training in 15, 20 minutes anyway. So what I'm trying to do is just sort of prime the pump, and if you're interested, I can always provide more information. The spousal abuse risk assessment tool, in its third version, is a well-validated clinical structured clinical guideline. It's published by Randy Kropp and others. I'll provide all the references. The perpetrator risk factors. So the version 3 is the first version that has victim vulnerability factors. That's not well validated, that part of it. The perpetrator risk factors are, but I think I'm a researcher. So when I look at this stuff, I think, well, victim, would never blame a victim. However, these are, if you see someone and he or she, the victim, feels insecure, has no other supports, doesn't have other resources that she can rely on, doesn't have easy access because of the controlling behavior of the partner, doesn't have access to community resources, feels that, well, he's under stress at work, and so he comes home, he has a drink or two, and then he gets angry. So the attitudes or she provides the rationale for him in a way for his behavior, and may have her own mental health issues. So these are things that you may see that would suggest, well, let's look at some, really, if you're working with the guy as well, and many couples see the same GP practices or the same GP, you might pay more attention. What are some of the, if a guy comes in complaining about his relationship, has he had relationship problems in the past? Has he had a string of problematic relationships? How are his friendships, his relationships with his parents, so non-intimate relationships, how are those? Problems at work, history of his own trauma or victimization. Does he do other antisocial behaviors? So does he steal from work, or does he speed a lot? Think the speed limits in Canberra are just stupidly slow. And so he's got all these, you hear this antisocial behavior, antisocial language. Does he have his own mental health disorder? Does he have a personality disorder? Maybe a bit antisocial. Substance abuse issues. So he thinks about, well, sometimes she drives me so crazy. Obviously, I'd never do it, but, I feel like sometimes just exploding. And what would that, what do you think about doing then? Well, I would never do it, but, some guys do. And then you hear this third person kind of talk about violence. And that's him. He's talking about himself in the third person potentially. And then distorted thinking about interpersonal violence, like society's gone mad trying to, relationships, there's problems in relationships. You're going to react. And so it's justifying his intimate partner violence. And if you know the person's a prior offender, what is he doing in terms of intimidation? Is he threatening his partner? Has he done physical harm, sexual harm? Then these are research terms, so severe interpersonal violence causing severe injury. Is he doing it chronically, repetitively? Is it getting worse? Is it escalating? And has he violated supervision like AVOs? They're very good indicators of increasing risk. Okay, so there is a shorter version of the SARA. The SARA is fairly long, and so it's those 8 questions, 10, 18, 24 altogether. There's a 10-item screening version of the SARA called the Be Safer, which is easy to use. Would take me an hour or two to train y'all, but we don't have time today. So, but another time, happy to do that for the network if you guys would like it as a training event. Not a problem. That's what we do. That's called community service, and we do that for free. So I don't have any other slides because I'm making up time for Tabitha. Any questions? Well, I guess we wait.
We're going to have questions on the sheets.
Okay. Thank you very much.
Thank you. So again, there's sheets to write questions on, and we'll come around and collect them later. Next up, we have the Access Mental Health Care team. We have Jade Nolan, who is a clinical psychologist, and she's now working in a managerial role. We've got Dr. Sonia Ress, who's the senior GP manager, and we've got Nasheed Sami, who is the consultant psychiatrist. Nasheed also works privately at Murrumbidgee. Thank you.
Okay. So my name's Jade Nolan. I am a senior manager with the Access and for the Access and Specialty teams, and the Access Mental Health team is one of the teams that I oversee. I'm just going to give a really brief kind of overview of what the Access Mental Health team is and what happens when a referral is received. Okay. So the Access Mental Health team is a centralised intake and triage service for adult community mental health services, and that's for both urgent and non-urgent referrals. So it's actually a relatively new service, so it went live, I think it was the late 2018, and it was actually developed in response to, I guess, wanting to centralise the referral process. So just as an example, prior to this service being developed, as a GP, you would have to kind of know where your client lived. So say, for example, if they lived in the Belconnen region, then you'd have to call the Belconnen team. Or if they lived in the Tuggeranong region, then you'd have to call the Tuggeranong team. But then if it was an urgent referral or a crisis situation, then you'd have to refer to the crisis team. So you'd really have to know the different numbers. So what this new team means is it's just one number that you're calling, whether it's urgent, non-urgent, doesn't matter where they live. So the idea is that it's easier for you to make a referral, but it also helps on our side to kind of streamline the process to make sure that all the referrals are being processed in a similar manner, that I guess different care isn't being provided by different teams. And so the main way that that the Access Mental Health team receives referrals are outlined on the slide. So there's the 24/7 mental health, the phone line. So that obviously is available 24/7, and that's for both non-urgent and urgent referrals. There is also, and that number is open to the public, GPs, any service can really, or carer or family member or friend or member of the public can use that phone line. But there is also a priority line that the Access Mental Health team responds to, and this is primarily used by emergency services. So it's primarily the ACT ambulance service calling through, or police, and that's to make sure that if there is that, a really urgent situation that does need an urgent mental health response or even an immediate mental health response, that means that we're able to respond to that in a timely manner. And then there's also the GP advisory line, and that line is available for GPs to seek advice for clients who, or for patients who may not be registered with mental health services. And although it's not a typical way of making a referral, often those phone calls, when speaking to the psychiatrist who's on the other end of that phone call, they may actually recommend that a referral is put through, and they will help to facilitate that. So once again, it's not the main way of making a referral, but it definitely can turn into a referral. And just to give you an idea of the number of referrals that do come through that Access Mental Health are responding to. So for the data for February this year, on the 24/7 line, there were 2,962 phone calls. On the priority line, there were 631, and there were 95 calls through to the GP advisory line. So that's a total of about 3,688 phone calls coming through in 1 month. And that does not include the 190 GP referrals that were received via fax in that month as well. And definitely over the past 12 to 18 months, we're definitely seeing a trend in increase for all of those different referral pathways. The numbers have been increasing. Okay. So when Access Mental Health team receives a referral, whether it's phone or through a fax, the clinicians triage the referral in accordance with a mental health triage scale that we have. So this helps them to determine, in accordance with that scale, what follow-up the person is needing and what time frame that follow-up needs to occur within. So just as an example, so the home assessment and acute response team, or the HEART team as we call it, if a referral has been triaged as being urgent, or essentially that person needs a face-to-face mental health assessment within 2 hours, 24 hours, or 72 hours, then that referral goes straight to the home assessment and acute response team so that they can do that outreach home visit to do that urgent mental health assessment. If a person following that triage assessment, and depending on what we know about the person, but if it looks like that person actually is going to need, they might not need urgent follow-up, but it looks like they will need ongoing follow-up, and their presentation is quite complex, and their functioning is significantly impaired, then a referral may be made to a community mental health team, which we're now calling community recovery services, and they're the ones that are the local mental health team, so Gungahlin, Belconnen, City, Woden and Tuggeranong. Then a referral may go through to one of those teams for longer term clinical management. And then there is also the comprehensive assessment or access comprehensive component of the Access Mental Health team. So in addition to triage, the Access Mental Health team also provides a short-term follow-up service. So that will include short-term intervention, comprehensive assessment, and supporting the person to link with appropriate services in the community, and that may include facilitating those referrals, or even having our allied health assistant actually helping them to attend appointments. So as mentioned, a person would be referred to the Access Mental Health, the comprehensive component, if they were needing non-urgent mental health assessment, intervention or support. So that is that they're not needing a face-to-face assessment within those 72 hours. But that there is an indication that they do need some support, and they do need to be seen by a mental health clinician or a psychiatrist. And Access Comprehensive provides that short-term follow-up for people for up to 3 months. And that short-term follow-up may include a face-to-face assessment with a mental health clinician. It could be phone call assessments and phone call welfare checks. There would definitely be MDT, so the multidisciplinary team discussions. So the team regularly gets together. There's OTs, social workers, psychologists, nurses, and the doctors as well, where they discuss a case together to kind of determine the appropriate care and treatment plan for the person. And it could, that follow-up will also include liaison with the GP or the referrer, and it could also include a psychiatric review appointment with a medical officer. So that is what the short-term follow-up could include, but what actually happens will look different for each person depending on what their needs are. So as an example, there could be a person that's referred, they're well supported by their GP, they're well supported by a private psychologist, they feel like they have all the appropriate supports that they need in place, but it may be that they just need a medication review of their medication, and that they need that, the GP might want that extra input from a psychiatrist and extra guidance around that. So that person may not necessarily receive ongoing follow-up from this mental health staff, but they may have that appointment with the doctor and maybe even another follow-up appointment to make sure that side effects are being monitored. Versus someone who may not have started on medications, may not be linked with appropriate services, and may need that extra phone calls and face-to-face contact with the team for the full 3 months to help them to link with appropriate services and I guess get the treatment and care that they're needing. And so then at the end of a person's episode of care, the multidisciplinary team will also review the case before a person is closed from the team, or to determine what kind of care that they may need ongoing. And so if the team feels like the person does require further intervention through mental health services, it may be that they then also go on to make a referral to a community recovery service or community mental health team to ensure that that person gets the follow-up that they need. However, I guess at the end of the episode of care, if it's determined that the person has, they've appropriately linked with services, they're feeling, I guess there's been some improvement in their presentation, and their medication is going well, then it may be that they're referred back to their GP if safe to do so. And I guess the main things you really need to know is that these are the contact details for Access Mental Health. So, like I said, it's a centralised intake service. If you're not sure about making a referral or not, this is the number to call. You can have a chat about it. You can have a chat for advice. You can make a referral. It's available 24/7. And as I said, the team will triage the referrals in accordance with the triage scale. So I guess probably another important thing to point out is that if you make a referral to the Access Mental Health team and you're with a patient, and I guess it doesn't always necessarily mean that a referral will be sent through to the heart team or the crisis team for a visit. It could be that the Access Mental Health team provides follow-up instead. So I guess kind of not setting up that expectation from the beginning that they are definitely going to be referred. It will be determined because the team will actually contact the person to, I guess, conduct that initial triage assessment and make a determination from that, as well as also taking into consideration the information that has been provided by you or the referrer. And then the other important line for you is the GP advisory line. So this is available Mondays, Tuesdays, Thursdays and Fridays, but it is only available for 1 hour, and that's from 1 till 2 p.m. So this is kind of more for people, if you have a patient, they're not linked with mental health services already, and you do want to speak with a psychiatrist around medication advice or treatment advice, then this number will get you through to a psychiatrist from 1 till 2 on Mondays, Tuesdays, Thursdays and Fridays. And I'll be around on the panel, but also during the break if anyone has any questions. Okay, I'll hand over to Dr. Samad.
Good morning, all. I guess we all share a common patients, and you would hear my voice at the end of the phone on a Monday and Thursdays, 1 to 2 p.m. So I hope that I have been helpful to different GPs in different ways and getting these patients across to Access team. So 10 or 15 minutes is not enough for us to cover anything on mental health, but I'll try my best to be as brief as possible on this. Okay. So we are not going through the diagnostic criteria for the mood disorders, but just briefly, when we say mood disorders, we are looking at bipolar disorders, depressive disorders, and then the bipolar is divided into 1, 2, and cyclothymia, as well as the depressive disorders are divided, and then we have the secondary factors which affect these diagnoses as well. Some of the common screening tools, very quickly, which GPs can utilize in their consults are the ones which Tabitha has already mentioned, the CHN, which is a simple checklist to measure whether the patient has affected by depression or anxiety in last 4 weeks or so. DES can be used as well. The CHN and DES is quite commonly used by you all. It's quite common. If you really want to get into depth of things, then the Beck Depression Inventory can also be used. And that also provides us with further information that this has been happening and the GPs have completed some of these investigations. Now, I'm just going to target on depression and anxiety today, just looking at the some of the practical tips or the pharmacological treatment based on clinical profile. So there has been a little bit of shift from the last college guideline in 2015 to what they have invented in 2020. And now what we are doing is following more so the clinical profile of the patients rather than doing the first line and second line. We still do, we haven't yet converted ourselves, and we still do use the traditional first line SSRIs and second line SNRIs. But what we are looking at these days is that if a person is presenting with the anxiety spectrum disorders, such as OCD, panic attacks, generalized anxiety disorder, we can use the SSRIs and SNRIs very safely. And later I will just briefly give you the information on the SSRIs. If a person is having some cognitive difficulties, learning, memory, decision making, then the good ones to use is duloxetine or Brintilex. The patients who are presenting with sleep disturbances, insomnia, the two which are commonly used is metazapine and the agomelatine or valdoxan. If a person is presenting with fatigue with the depressive syndrome, then bupropion can be used. However, bupropion is not TGA approved in Australia for anxiety and depression, and so it is quite expensive medication. And we use it as third or fourth line of treatment when a person has really reached that treatment-resistant stage. If someone is experiencing pain, and most of you are do have these common patients with pain and depression and anxiety, we prefer duloxetine and tricyclic antidepressants. Those who now come under the psychomotor retardation or melancholic type of depression, then mostly tricyclics are used. However, it does come with its side effects. And lastly, if people have psychotic symptoms, then we definitely add the antipsychotic medications with our antidepressants. Now, I think that Tabitha has already covered a little bit on that. What we need to see when a person is presenting to us is we need to institute that they are doing the lifestyle things. And that's why from Access Mental Health, you would receive a letter right in the beginning. Please talk to your patients about lifestyle and things like that. And I guess most of the GPs do that quite well. Also implementing education or psychoeducation and the types of psychological interventions, referring another mental health care plan to the psychologist, looking into other psychosocial issues such as providing some sort of support, and then doing the risk assessments. The choices of the medications which we usually use is looking at the patient profile. Are they small? First of all, what they're presenting with. Is it more prominent anxiety or more prominent depressive symptomatology? Are there psychosis creeping in? There's OCD creeping in as well. And then we tailor the medication according to that person's profile, but also looking at metabolically what the person is like. And we try and consider if this person is able to tolerate this medication, as well as looking at the efficacy of the medication. So some of the medications which are commonly definitely used are the SSRIs. SSRIs are quite tolerable medication comparatively to SNRIs or metazapine, the SNRIs. So this is just the class of antidepressants. It's a little bit of a crowded slide, which we have the SSRIs are the selective serotonin reuptake inhibitors, which are our normal sertraline, escitalopram, cipramil, fluoxetine, fluvoxamine, paroxetine. And then we have the SNRIs, which are the venlafaxine, desvenlafaxine, duloxetine. The other two, which we don't have here in Australia. Then we have the selective noradrenergic reuptake inhibitors. The NRIs are the reboxetine, atomoxetine. We don't usually use reboxetine these days. Atomoxetine is used as a non-stimulant for ADD, ADHD. And then we have the bupropion. bupropion is mainly for the quit smoking, which is TGA approved, however not as an antidepressant, but we have started using for some treatment-resistant patients. And then we have the noradrenergic and specific serotonin antagonists, which are the metazapine. Mianserine is, again, not commonly used. It is used for only atypical depression or where nothing has worked for a person. And I don't think in Australia now, at one stage they had stopped the supply, so some of the pharmacies are getting some supply, but it's really, we are not able to find much of the supply. So some of the, when we look at the patient profile, what they are presenting with, we also want to look into the side effects of the antidepressant medication, how it affects an individual. And as you can see, that the how it shows is the fewer cardiac side effects are the SSRIs, the valdoxan, the Brintilex. Some of the less sexual side effects are again the metazapine, valdoxan, and bupropion. We don't talk about mianserine as much because it's not that available. And then the less sedative ones, because we really don't want to make people quite sedative by giving these medications, are the valdoxan, Brintilex, fluoxetine, and escitalopram. Some of the less weight-gaining ones are the SSRIs, SNRIs, and valdoxan. One of the weight gainer is the metazapine. It is one of the worst ones, so we just need to be careful, specifically when giving it to young individuals. Some of the practical strategies which we end up looking at when treating patients. We all, I guess by now, GPs, they know their patients quite well. They know who's quite anxious or depressed. They have seen them several times, or even if they see them once, they are able to understand most of these things. So when giving them the medication or prescribing, we look into the history, just very quickly tease out some of the target symptoms, the neurovegetative symptoms such as sleep, appetite, motivation, concentration, the impact on their work. And then we look into what are the medications they have used in the past, like the SSRIs, SNRIs, and if they have had good effect. If a patient has had good effect on a medication, either it be a SSRI or SNRI, and they have now come to you with no medications for a certain period of time, go back to the medication which has worked for them the best. Try and use a very small dose initially and then increase. So that one of the policies or one of the rules for antidepressant is to start at a low dose and gradually build up the dose, optimizing the dose to at least the first 3 weeks. After the first 3 weeks, you can really go up to the maximum dose. And if that is not working, then you can do the augmentation. So either add another antidepressant, which is maybe metazapine or valdoxan, or an antipsychotic. A small dose of antipsychotics such as Seroquel, olanzapine, or risperidone can be augmented for these patients, but we need to give them on a private script. And the Seroquel, risperidone are quite cheap medications these days. If a person has been on trial of 2 to 3 antidepressants, in the past on good doses and augmented with another antidepressant, antipsychotic, and still is depressed, anxious with suicidal ideation, then a mood stabilizer such as lithium lamotrigine can also be added. And that's the stage, I guess, a referral needs to be done. So we try and give at least 12 weeks of medication, one medication or augmentation, small dose of augmentation with the antipsychotics for at least 12 weeks to see if there is any change. Do not change the medications frequently. Try and optimize the doses of medication because anxiety and depression, this medication takes at least 2 to 4 weeks to work. And then once we are changing the medication, the patient still remains anxious and in a depressed state. Some of the antidepressant switching strategies is you could do a direct switch, and I'm happy for these slides to be sent across, the 2 or 3 important slides. So we could do the direct switch, which is, it's suitable when a first antidepressant is used for less than 6 weeks. Few examples could be a SSRI to SNRI, such as duloxetine. So that's a direct switch which a person can do. Or taper and then immediate switch. So first antidepressant would be reduced and we stop it, and the next day we start the new antidepressant on a smaller dose. Taper and then switch after a washout period. That also depends on the half-life of medications and the chances of relapse. So we try not to use more of those the tricyclics and the monoamine oxidase inhibitors because they require a washout period. SSRIs and SNRIs, very quickly switching from one to another, it is quite easy. The other one is cross-tapering. We do quite a bit of cross-tapering with the antidepressants. Probably in GP land, it would be a little bit difficult because you're worried about serotonin syndrome. So what we do is reduce the first medication to, for example, it's sertraline. We come to 50 milligrams of sertraline. We start a SNRI, and then within that week, we go down 25 milligrams of sertraline and put the other medication up. So it can very easily be done. For example, from sertraline to venlafaxine or desvenlafaxine, it can easily be done without having the complication of or worry of serotonin syndrome. We still, when we are doing that cross-tapering, we really need to just be mindful of some of the contraindications. The CYP450 interactions, for example, fluvoxamine cannot be given with valdoxan. So MIMS will usually tell you the interactions, and you can always check the interactions as well. So this is, again, a little bit of a crowded slide. It's from Maudsley. It shows how to switch. It's a good idea to just print this out and put it on your desk or on the wall so it's easy to look into it. Sorry, I just had to rush this because it's very difficult to talk about antidepressants or antipsychotics in very short periods.
Thank you, Nishi. We're nearly finished the first session. I'm going to introduce Dr. Jessica Sloan. She's one of our clinical editors working on the HealthPathways project. So she's a GP working in Canberra, and her role is to write and review the pathways that you use.
Thanks, Louise. I've only got 5 minutes, so there we go. I think it's quite fun to make psychologists and psychiatrists fit into a time frame of a regular general practice. I'm going to just show you a couple of the pathways that we're working on. So HealthPathways is designed for GPs to use at the point of care, so basically in clinical practice. It's written by both Southern New South Wales and Canberra GPs, basically, who are clinical editors. So we'll take a page that either already exists, we'll review a page, or we'll write a page from scratch, and then what we do is we send it off to like local specialists. So it's designed to be localised in terms of what kind of services are available. I don't know how to put that up on there. Okay, right, great. This is going to put the pages up. So there are 2 different types of pages. We've got clinical pages, which I guess probably not so much used by the more experienced GPs. A lot of the registrars will use them, but it's good, like anytime something comes up that you haven't seen in a while, it's got sort of assessment, what kind of management, and what kind of things to do for that. So, every now and again we'll use one of those type of pages. We have been working on the anxiety and depression pages. So it's one of our clinical pages. So in terms of what kind of things to assess and manage, what kind of clinical resources and patient information are available. So those are sorts of things you can use in your practice. You can click on the K10, you can click on some resources, print them out, hand them off to the patients, and then just sort of keeping up to date on what kind of referrals there are. So what kind of urgent referrals for mental health, and we've covered ACT and Southern New South Wales. So if you've got a patient who lives in Goulburn or they're down on the south coast, you can find out what kind of what the referral process is for that area. All the phone numbers are up there, and yeah, I guess the referral pages are quite useful. But also just sort of remember that it is designed like for GPs. So if you have things that come up and you want to put them on a page, there's a send feedback option. So, you know, try and sort of share resources with your colleagues. And that's it. I think I'm under 5 minutes. And there you go. You can either search for it or you can just use the drop-down boxes on the left-hand side. But yeah. You've all got the login and password on your table. Great.
Okay, thank you everyone for your questions. Our first question is Tabitha. Ideally, for the diagnosis of the ADSD, ADHD, that's really hard for us to get. Where do we get it from? Who should be doing that?
That's a very good question. So when it comes to diagnosis, there are a couple of pathways for adults. So unless there's evidence of intellectual disability, I wouldn't be referring to a psychologist for expensive cognitive testing. What we would want to do is refer to clinical psychologists for clinical assessment. We can do that diagnosis for you, and then we would recommend referral to a neurologist for prescription of stimulant, or in some cases a psychiatrist if there's comorbid mental health conditions.
Okay. On that same topic, the differentiation between trauma and anxiety and ADHD, how do you tease that out? Years and years of a degree.
Yes, yeah. Thanks, Jess. I think when we're looking at neurodivergence, we're really looking for that cognitive overwhelm. So we would see, in addition to, say, trauma factors, we would see the fixed interests. We would see, overwhelm in terms of sensory sensitivities. When it comes to, I guess, ADHD and trauma, sometimes it is very difficult to tease that out, and we may not actually be able to do that. What I would find is often the final step is trialling a stimulant. And if that's useful and helpful, then that's usually something that we would stick with. If there's too many side effects and it's not effective, then we would say usually it's not so much neurocognitive.
Thank you. We're going to move on to Prof. Bohr. One of the questions is, does direct questioning of the work with the perpetrators of physical violence, is it a good thing to do, the direct questioning about violence?
Well, I think it might be more that you might reflect that you have some concerns about some of the issues they're presenting, and you may query whether or not they may want a referral to a psychologist to discuss some of those issues. If a person brings up the risk issues themselves, then they may be willing to explore them, but I wouldn't be priming the pump for more. You don't want to potentiate violence either. So I think you have to be very careful about direct questioning, because it sounds like you're getting at a checklist, and if he's a suspicious fella, he might be thinking, you're kind of getting me. And that might, then he may then go home and say, what did you tell? So I think you have to be very careful. I think the issues are more for your sensitivity and for your assessment, and then say, well, if there's relationship issues that you're struggling with, maybe you could discuss those with a psychologist. Mm-hmm. And then, go ahead.
Yeah, well, on exactly that note, in terms of out-of-prison programs for perpetrators of violence?
In terms of?
Are there any?
Well, there's programs in the prison.
Yeah,
so there's a domestic abuse program, and that's also available in the community through community corrections, but that's only for people on orders. And of course, there's the domestic violence center. that has programs. There's quite a raft of programs available.
So as a GP, if we had a perpetrator of violence or that was insightful and wanting to change their relationships, we would refer through the domestic violence crisis
Yes,
service.
so DVCS would be the place to start.
Great. All right, let's go to Jade. Just with your referral options, really quick one, can we use HealthLink, the electronic referral system that we use for Canberra Hospital?
I do know that we were setting up, there was an electronic referral that was being trialled, and I think we do receive some.
We receive the electronic referrals from general practice. I'm not sure about via the hospital system though.
Or the HealthLink
So
system.
we do receive I think it's in blue,
Yep.
the background is blue. So yes, we do receive a combination of that and then the typed referrals that just come through medical director or whatever it is, and then fax through.
Okay.
Just my understanding, when it was initially set up for us to receive referrals through that electronic form, I think it was only available to certain GPs though. I think it was a trial for mental health, so I don't know if it's available to all GPs.
Okay. So, next question. For which patients can we use referral to the Access Mental Health team? Is it just non-urgent? And does it include providing short-term support and links to mental health team? Yes.
So basically we see in Access a whole range of presentations and patients from general practice. So if as a GP, we see mental health as one of the top things in our day-to-day work. If you think that this patient is not responding, has more acute issues, has got an extensive background of other conditions, suicide attempts, other risk issues, then definitely send in. On the flip side of that, if you have any questions, you've got the option of referring or using the GP advisory line, ringing Access Triage to also just get an idea of whether that's an appropriate referral. So I guess the answer is there is no wrong referral because everything that comes in will be triaged and discussed at that multi-team level.
Okay. So following on from that, exactly how much care or counselling, and I think I know the answer from that previous answer, does the case manager team give to each referral?
So the Access team, there is no case manager. So the way to kind of visualise what has happened with the distribution of care, I guess, in Canberra community mental health is the Access team is kind of like the umbrella input team, and under that are all the community provider recovery services. So previously, as Jade was saying, in Canberra, you used to refer to the demographic location of the patient, which means that every referral used to come through. It used to take months before anything got, as other outpatient clinics. This is far more efficient and effective use of that referral time. So this model looks at all the incoming information, referrals from hospital and community GPs, and then from there it is worked out what the needs and management will be. And that is either within the Access team, or if they're not able to be then sent back into general practice at the end of our management, we then refer as a team discussion to the Community Recovery Service.
And I guess I'd just add for any of the services, whether it's Access, Heart, or one of the clinical management teams, the frequency of contact will always be determined by the person's needs and how they're presenting at the time.
Thank you. Okay, next question for Nishi.
I just wanted to add that Access team does not provide any counselling services. So we triage it, then we just see if they're acute, if they need to be in contact, or they need to have diagnostic assessment, then it's face-to-face or clinician phone call, but we don't provide any sort of counseling. The recovery team, where there's clinical management, they are able to facilitate some of those psychosocial things, But because I think that there is a misconception that the specialized mental health service in ACT would also be providing psychological interventions. So the day-to-day psychological interventions are done through GP mental health care plan to the community psychologists.
Thank you. Okay, next question. You mentioned a couple of treatments that were not on the PBS for their treatment. Is there any way of helping people pay for that non-privately?
When we are doing the augmentation with the antipsychotics, it's difficult. We can tell lies to the PBS, we can tell lies to Medicare. If they have personality disorder or personalities with, and we think that there is a little bit of bipolar, we still can use some of those codes. If they have some psychotic-like symptoms, we still can use the code for schizophrenia because it will come under the umbrella of psychosis. But if we are looking at those Valdoxan and Brintilax and Buprop, no, there is no other way we can assist in any, yeah.
Can duloxetine be used with the other tricyclic antidepressant?
Yes, duloxetine can be used with other tricyclics. However, the tricyclic has to be on a lower dose. So you can go up to duloxetine 120 milligrams, but do not exceed the tricyclic beyond 50 milligrams. So most commonly, nortriptyline or amitriptyline are the most common ones. Yeah.
Keep the dose
yeah.
low.
Just the one which we have to be careful with is the clomipramine. So, and that's not quite widely used. That's more commonly used in OCD. So we don't try and combine clomipramine with other SSRIs. But the nortriptyline, amitriptyline, we can. Yeah. And it's quite commonly used by GPs as well as pain specialists and us for the comorbid pain and depression.
Great. Okay. So if we've got someone with bipolar symptoms and they're not being managed with an SSRI, what do we do next?
Not being managed.
If they're not managed, if
they're not okay. So if there's if a person suspects there is bipolarity, we very quickly have to rule out, because there are a lot of people who are in the early 20s, and the borderline personality patients may sometimes present in that bipolar manner. So we very quickly may need to rule it out, that is this a personality or is this a real bipolar? Is there a family history of bipolar? If it is bipolar and you suspect that there is some bipolarity, then if they are on any antidepressant, reduce the antidepressant within that 1 or 2 weeks and seize it and put them on. Most commonly used mood stabilizer is the quetiapine, though it does come with its own side effects, but it's the easier one to put them in rather than putting them on lithium or sodium valproate, because they bring, if a diagnostic assessment has not been done, I think in the GP place it's not very easy to put someone on lithium and sodium valproate, because you really worry about the monitoring and all those things. So, yeah.
Okay. And then in the question about augmenting rather than swapping, so if I've started an antidepressant and it's partially working, would I consider augmenting it with something else or swapping to a different agent?
So trying to optimize that antidepressant, for just give an example, if it's sertraline, we have gone up till 200 milligrams. Then, so I think in the GP, you can go up till 200 milligrams, and it is a PBS. You can call Medicare to get the approval. You can then do a augmentation if the patient is able to, with either Valdoxan or with a antipsychotic medication or with small amount of metazapine, depending on the clinical profile.
So it would depend on their response to the first agent?
Yeah.
Okay. Well, I don't want to go over time. Oh, I've got more questions. So I am going to go over time. Okay, which SSRI has the least agitation or irritation?
It's very difficult to say. It again is according to the person. So what they are actually physically presenting, are they big, small, lean? We don't know their metabolism. So I would through experience, it's escitalopram, which is least. However, escitalopram can cause a lot of emotional numbness. Fluoxetine is more because it has accumulative behavior and it can really start, so that's why we start them on a very low dose. Sertraline is in between, not as activating.
And so I think you'll give me a similar answer for the sedating properties. It'll depend on the person.
Yeah. So yeah, again, depending on person as well. But metazapine, valdoxan have got more sedative properties than the other SSRI and SNRI. However, if a patient has been prescribed a SSRI and SNRI, and they say, look, I really feel sedated during the day, I'm feeling quite drowsy and tired, you can tell them to change it to evening or night dose. So I just had, yesterday, I had a phone call from a patient who was prescribed desvenlafaxine, and she said that for the first week she took it, she was very tired during the day, and we said, okay, just change it to evening time. Yeah.
Okay. Thank you everyone for your input today. It's been great to have your... So welcome everyone to our afternoon session. We've got 3 speakers that are covering eating disorders as much as they can in their time slot. So our next speaker is Catherine Bell. She's a clinical psychologist and the Eating Disorders Service Coordinator at the Eating Services Program at Canberra Hospital. She has an extensive clinical background and she's looking forward to helping you support people with eating disorders in the ACT.
Okay, thank you. So, in the time today, one of the questions that the HealthPathways staff passed on to us about what people would like to get out of today is what actually works in working with eating disorders. I would love to give a really easy answer for that, but I'm going to try and answer it by thinking about what things to consider in terms, including things like function of eating disorder behaviours, what goals of eating disorder treatment might be given the function of the behaviours, a model to consider where to refer, and a brief discussion about what services are available in Canberra within sort of that spectrum. And given I am from the Eating Disorders Program, talk a little bit about what the Eating Disorders Program offers and what kind of patient would be appropriate to refer to the program, sort of given what the program offers. If there's time, I'll try and talk a little bit more about the therapy, but I suspect that that won't happen. I do, I guess, want to... the National Eating Disorders Collaboration have reported statistics that 16% of the population may experience disordered eating or an eating disorder. So I guess I do want to start by not making any assumptions about people's relationship with food or their body, acknowledging that some things that we talk about can be triggering, and if anything is triggering, I do ask, to sort of seek supports and practice your self-care. So I guess before I get started, I'm not going to go into diagnostic criteria, but just sort of have a list. I've just got a list here of what are examples of disordered eating. And I guess the difficulty with working with people with eating disorders is that some disordered eating is so mainstream and normalised and endorsed, and so it's really, one, it's really tricky to pick up on, and 2, it's really tricky to sort of motivate someone to work on changing behaviours when it's like, but everyone does it and everyone does do it. So to me, the first step in trying to support somebody with an eating disorder, if they're coming to see me, is what, and I guess this is something to think about when you're working with a patient with an eating disorder, is trying to get a sense of what is driving that eating disorder behaviour. And the slide I start with is it's not about the food, because so many people who I work with come in saying there's too much talk about food. Everyone only cares about food. Everyone only cares about the weight. No one cares about how the eating disorder is helping them, even if we know that there are negative consequences to their health. So by understanding what's driving the eating disorder behaviour, we can develop empathy and develop a relationship where the client or the patient may feel understood and be able to sort of even start to open up to engaging in therapy. And from my perspective as a therapist, understanding the function can help think about, well, what are the strategies that are going to be helpful for this person. Now, I've compiled a list here. This is just based on my clinical experience. It is by no means exhaustive. It was me spending 30 seconds thinking about what are the top non-food reasons why someone, what would be the positives in eating disorder behaviour. So as I've said, got here, you know, for many people it can be a way to manage emotions, and that can include not eating and overeating. And a lot of people report that not eating numbs really overwhelming emotions for them. I haven't got the reference, but there's been some studies that show that vomiting actually releases endorphins. So there's that, you know, kind of that immediate positive reinforcement, which we don't normally think about. But for some people, there's, you know, a real sense of achievement, and again, that's really condoned in our society. Like, how many times have you maybe said to someone, or someone said to you, "Oh, you look great, you've lost weight," and yeah, for some people it might actually be a real sense of identity, that real really feeling special, like I need to stand out, I need to be the thinnest. The next two, like control and avoiding other things in life, like if you're working with someone, like let's just say, you know, a mum with 2 young kids, relationship issues, works out of control, food is one thing in life that they can control. And some people, you know, we might even make sense of it as, you know, the person, by focusing on food, then it's an excuse to not focus on what are the kids doing and things like that. For some people, it can be a form of communication. In my experience, people may not articulate that at kind of the beginning of treatment, but certainly as sort of we're progressing through treatment, some people will say that they're afraid that if they do start eating regularly and adequately, or they regain weight, people will think that they're okay, and they're not okay. And for some people, sort of eating disorder behaviours can be a form of self-punishment. There might be this, I don't deserve to eat, or I don't deserve to be happy, or I need to punish myself for something. Now, while the function of disordered eating isn't always about the food, well, it is also about the food. So I've put up Maslow's hierarchy of needs here just to demonstrate that we need to meet physiological needs such as food before we can think about addressing psychological needs. In the 1940s, pre-today's ethics, there was a study done in the context of supporting prisoners of war in World War II, and there were these men that were their calorie intake was reduced, they were very heavily monitored, and they learned a lot about the physical and psychological effects of starvation in itself, and things, you know, some of the things included like lower mood, increased obsessional thinking, harder to make decisions, just being more irritable and moodier, harder to regulate emotions and harder to concentrate, which we can see as symptoms of depression here. So what they learnt in that study was adequate nutrition and health restoration actually reversed some of those psychological symptoms. So that's why food is really essential in eating disorder treatment. And the last point is that for a lot of people, you know, there's this fear of fat, there's this fear of eating a particular type of food or a particular quantity of food is really scary. And I often joke with people that psychologists are evil. And what we know is that the more we avoid the thing that scares us, the scarier that thing becomes. So to recover from an eating disorder, we need to face the thing that we're scared of, which includes particular foods, quantities of foods, returning to a particular weight. So I guess with that in mind and thinking about what are the functions of an eating disorder, goals of eating disorder treatment, regardless of the treatment modality, is initially we do want to establish a pattern of regular and adequate eating. We want to reverse the psychological and physical effects of starvation. And then we want to, I say and then, but you know, sometimes it's at the same time, try to teach strategies to address the maintaining factors, such as learning to regulate emotions, exposure to feared foods, developing interpersonal and communication skills, enhancing other areas of life. I guess one important thing that I just thought of yesterday, which I didn't put on the slide, was that a goal of treatment may be to improve quality of life and keep a person alive as well. I think that's the hard thing to sit with, because we really want to, we would love to have full recovery for all our patients, and there are some patients, and to generalise, that might typically be the patients with longer term eating disorders, and who may not be in a place where they're ready to make change, where we need to sit and we need to hold physical risk and try to support improving quality of life. Okay, so what I have put up on this slide here is a model in terms of thinking about where do we refer a person who presents with an eating disorder. This sort of matrix was created by a lady in Canada named Josie Geller, and it's about trying to come up with a structure to support clinicians to think about the most appropriate service to refer someone with an eating disorder. So it is based on the Canadian model of care, but we can apply it to the Australian context. So it looks at medical stability, severity of symptoms, and a patient's readiness to make change. So at the top, for example, if someone's medically unstable, then we need to look at trying to get them to hospital for medical stability in like a general medical ward. The process in Canberra is typically to go through the emergency department. If the next stage we look at is symptom severity. So if somebody has more severe symptoms, then they're likely to need a higher intensity of support. They might need meal support, they might need more frequent sessions. Someone with lower intensity or severity of symptoms may benefit from seeing a psychologist once every couple of weeks, or a dietitian. The third thing we look at is readiness to make change. So if we're looking at someone who has really severe symptoms and ready to make change, we want to be sort of looking at maybe a day program or specialist inpatient program. That does not exist in Canberra at the moment. There is work and commitment from the government to try and develop these programs, but they are still going to be a little while away. So at the moment we are looking at interstate referrals. If someone's not in a place where they're ready to make change, then we're looking at outpatient support, outpatient treatment, but with inpatient support. So it might be sort of referring to a general psychologist or mental health team working on quality of life, or and sort of you guys continuing to monitor and escalate to hospital if they become medically unstable. If someone has, severe symptoms, or less severe symptoms, and motivated to engage, then, we'd be looking at referring to, a specialist service or psychologist with expertise in eating disorders. So that might be the Eating Disorders Program. There are several psychologists and dietitians in Canberra who do have experience and an interest in working in eating disorders as well. And then the last group, sort of the not really severe symptoms, not motivated to engage in treatment, again, looking at maybe general psychology, general mental health team, Headspace or something like that, or even sort of continuing GP support and focusing on trying to motivate and enhance readiness to change. Easier said than done. So I did quickly want to talk about the Eating Disorders Program because I'm very aware that we have long waiting times and people are always asking what are the criteria. So the Eating Disorders Program sees across the lifespan. We offer two types of therapy in the first instance: family-based therapy for young people and cognitive behaviour therapy for adults. We provide these therapies because treatment guidelines recommend family-based therapy as the first-line treatment for basically all eating disorders in young people, and CBT is recommended for all eating disorders for adults as well. That's not to say they are perfect treatments. Their efficacy rates for family-based therapy, we're looking about 30 to 50%. CBT, they say 2/3 of people have a good outcome, and 2/3 of people who complete treatment have a good outcome. So we see people who present with a primary issue of a moderate to severe eating disorder underpinned by weight and shape concerns. And that's primarily because the therapies that we offer do focus on weight and shape concerns. We offer an active therapy, so we want the person to be in that ready to make behavioural change. We see ACT residents only. I've got a BMI criteria of 15 to 40. That's because the treatment manual that we use for the CBTE recommends for it's been researched for that BMI range. My clinical experience is that for people below 15, they need a higher intensity of support that just isn't available at the Eating Disorders Program. And we do require a GP referral. Now I think it's available on HealthPathways, and also we're happy to fax it to people as well. So we ask questions in that to help us make a decision of, one, do we think that the therapy that you offer here is going to be a good match for the person, and two, to prioritise where they are on the waiting list, because we do have quite long waiting times. We try to prioritise people who are more severe presentations, particularly hospital discharge, and even then we don't have the capacity to see people straight away, but we do prioritise them. Just, for your benefit, things that we take into consideration, and these are things that are on the referral form. Is an eating disorder the primary presenting issue, or the best way of understanding the person's difficulties? If those weight and shape concerns sort of aren't there, like for example, if there's trauma or ASD presentations, you might be saying actually a different service is more appropriate to support this person, or perhaps even in conjunction, or do some other work first before the work that we do. I will say with ASD outcomes, there's a high comorbidity with ASD and anorexia. I saw a recent study saying up to 30% with anorexia have ASD, and they have poorer outcomes. And my personal opinion is I don't think the manualised treatments really take into account some of the extra challenges for someone presenting with ASD. Also, if the person doesn't identify as having an eating disorder, it might not be the time to refer to the eating disorders program, because the eating disorders program, we're going to talk about eating and eating disorder, and if someone's not feeling like that's a good fit for them, they're just going to not engage. And it might be refer to a private psychologist or another health service, but someone where they have eating disorder in mind and can work on supporting to increase that motivation to change. We do look at severity to sort of get a sense of, is the frequency of treatment appropriate for this person. One of the things we do take into consideration is how has the person responded to maybe a lower level of intensity of treatment or a different type of treatment. So if somebody has had treatment before, we will try to contact the previous providers involved to get a bit of a sense of how did things go, what are you hoping to get at, like what do you think is going to be different about coming to the eating disorders program. Sometimes people are really engaged with private psychologists or dietitians, and we get a referral to the eating disorders program, I think just because we're the eating disorders program, and it's like, well, actually they've got a really great relationship with this person, and there's progress there, so we don't want to like rip that apart just for that. And the last thing is, does the person think that the treatment modality that we do is appropriate for them? Because if not, it's not going to be a good fit. I can see my time is done, so thank you for having me.
Thank you, Catherine. Can I just say that all the slides will be available after today, and this presentation is being recorded as well. Okay, next we have Vivian Lewis, who is, we're so excited to have here today. She's a clinical psychologist, and she's the director of the Masters of Clinical Psychology program at University of Canberra. She's got more than 15 years working with people with eating disorders. She's written 2 books, Positive Bodies, Loving the Skin You're In, and No Body's Perfect, spelt with a Y''S. And she's also working on a book directed at us, GPs, in helping us support people with eating disorders. Welcome, Vivian.
Oh, well, thank you very much for having me here, and I am really thrilled to see a couple of familiar faces. I know there's a couple of GPs in this room that I have spoken to numerous times in regards to sharing patients, so nice to see some of you. So what I'd like to present to you today is around my experience as a clinical psychologist in private practice, working with people with eating disorders, and specifically for today, looking at a study that was conducted at the University of Canberra in 2019 with an honours student of mine, Emma Coy, where we actually interviewed some of the people in this room around your experiences of working with people with eating disorders and what you think works and what doesn't, and then looking at the research literature from the patient's point of view, so what they say works and what doesn't work. So as I've been introduced, so clinical psychologist, and I'm working at the University of Canberra, so I head up the clinical master's program there, so where we're training the next group of clinical psychologists. And if you want to get in contact with me in regards to anything at the university or in terms of private practice, I do offer supervision for GPs in regards to how to work with some of your patients with disordered eating. So my details are there. So let's have a little bit of a look at what the research says works and what doesn't work. First of all, eating disorders are extremely complex conditions, and they're extremely severe conditions as well. And a lot of GPs experience a lot of angst and a lot of worry when presented with somebody with not just disordered eating, but an actual eating disorder diagnosis. As Catherine was saying, the people presenting with disordered eating is actually quite common. It's also quite common for people to have body dissatisfaction and concerns about their shape, weight and size. But eating disorders is where those concerns become the main goal and something that's really significant and becomes a real focus in a person's life and can be very tricky to treat, whether you're the GP, the psychologist, dietitian, psychiatrist, social worker, community nurse, and it's important that we understand what our patients want and what we can do as professionals to help them. So the study that we conducted in 2019 was a qualitative study where we interviewed GPs around their experiences of working with people with disordered eating and eating disorders. So first of all, thank you to all the wonderful GPs who took part in that study. And one of the main things is to acknowledge, as I just said, that working with people with eating disorders is very challenging and you can't do it on your own. So as a GP, you can't be the only person who works with that person with an eating disorder because it is very challenging and it's important that you don't work in isolation. And so knowing who you can refer to, who can help you is really important. One of the main things that GPs have been talking about is that when presented with somebody who has an eating disorder, they feel very alone and they feel very concerned about the risk that you're taking and the responsibility around that risk, because when we're dealing with people with eating disorders, it's not just the psychological side of things, but it's the physical side of things. And unfortunately, eating disorders have a very high morbidity rate, so the chances of your patients potentially having extreme health issues, potentially even dying, is a realistic thing that GPs have to face. So some of the things that, when we were conducting this study, that GPs were talking about was a real reluctance to what we say opening the box. So realising if you ask a client about their eating, about their body image, and the client starts to open up about that, it's not going to be able to be contained in a 10-minute consultation. It's something that's going to take you an hour, maybe an hour and a half, to work out what's happening for that person, to work out a plan of action, and to get people involved. So it's an enormous ask of GPs. And so one of the main problems is the time, the time that you have to actually work with patients. And so the reluctance was, if I don't ask the questions, then I don't have to follow through with it because I haven't got the time. I want to be able to give them the time, but I'm worried that I'm not going to be able to give my patient the care that they need. So sometimes a reluctance to ask some of the hard questions. With people, any presentation, any psychiatric presentation, but particularly with eating disorders, the building rapport and your patient trusting you with information that might mean an ambulance is called, or might mean a child's parents find out, or it might mean that the Access mental health people are called. So they need to have the rapport built so that they trust you to be able to open up and tell you what's really, really going on. And that can take quite a while. So often GPs will find that they might have been seeing a patient, it might be for a year or 2 years, and they don't find out about this really severe eating disorder till way down the track because the person hasn't felt comfortable enough to come forward with it as yet. As Catherine said, recovery takes between 2 to 5 years once someone has sought treatment. So it's a long time. So for your patients, you're going to be working with that client or with that patient with their eating disorder for a long period of time. It also has a poor prognosis. So we know that people's physical health is really compromised, and sometimes people don't see the physical health effects till years down the track. So when I've been working with men or women who are middle-aged, who might have had that eating disorder since they were 12 years old or when they were adolescents, that's a long period for your body to be under enormous stress and to be really unwell. And often those people present with issues around their hearts, around kidneys, liver, brain functioning. They can often present medically as quite unwell, and underlying it is an eating disorder. The managing the risk, don't work alone. You can't work alone and hold the risk, because you will be worried. You'll be worried about that person's physical safety and their mental health. And so when I work with people, I always make sure there's a GP involved, there's a dietitian involved, there's usually a psychiatrist involved, and there might be also nurses or social workers, as well as people's parents. Even if that client is an adult, actually engaging parents or partners or carers, so that there's a team of people looking after that person. That's really, really important, because as a GP, you often work in a really isolated setting, and so being able to engage other professionals is really, really important. So forming your multidisciplinary team is usually the first step. So when you actually are talking to your patients and you think there might be an eating disorder, is encouraging them to seek help from a psychologist, seeking help from other people who can help as well. So what's important to GPs? GPs were saying what's really crucial is to have really good communication with the multidisciplinary team that you have. So the GPs that I work with have been fantastic in that they will contact me when they've seen the patient for a quick update. When I've seen them, I will relay that back to the GP. I do the same thing with dietitians, do the same thing with the psychiatrist, so everybody knows what's going on. Of course, that's really time consuming for everybody. And again, that issue around the time you've got to be able to do that follow-up is limited, and that's really, really hard. But when you have that really good communication with a team, you feel supported and you don't feel like you're holding that risk all by yourself. And getting support from other professionals. So like I said, I often offer GPs sort of a little bit of supervision, a bit of mentoring around working with people with eating disorders, because it's really, really tricky. And if you've not worked in that space before, sometimes it's a bit difficult to know what to do or where to start. And with patients, when you know that there are eating or body image issues, is when they see you the next time, making sure that they book in for that long consultation so that they're able to get the time from you that they need. What do patients say? So what do patients say works and what doesn't work? Most patients hold back from being honest with their GPs around eating and body image, often because they're really embarrassed, or they're worried there's going to be some stigma. They're also worried about what you're going to do as a consequence. So are you going to tell their parents if it's a young person? Are you going to, call mental health services? Are you going to call ambulances? Are you going to admit them to hospital? They're worried about what's going to happen. So often they hold back till they really trust you and have really built that rapport, and then sharing that information with you. Patients also really despise being weighed when they come to see the GP. That if you think about it, if your main concern is around your weight, then going to the GP and being put on the scales for a lot of patients is actually really traumatic. And that's one of the things that they talk about. the problem is it's important to actually monitor the weight, particularly when you're talking about a condition like anorexia nervosa, where you need to see how that patient is progressing or not progressing, as the case may be. So it is important to weigh them. One way of getting around that is, first of all, asking their permission. Is it okay? And do they want to do blind weighing? So where they don't actually see the number, they don't actually know what they weigh, that's something that you keep, and you might communicate that with your team as to how that person is progressing. It's also the issue of, for a lot of patients, where their weight is in a healthy weight range or even overweight or obese, and being weighed, and sometimes it can be a dismissive thing. Your weight's fine, your weight's in a healthy range, so we don't need to worry about it. I work with a lot of clients whose weight is in the healthy weight range, or they're in the overweight or even the obese range, and they are extremely unwell. So very, very unwell. I think of women I've worked with in their early 30s who are in the overweight range, but they have a restrictive eating disorder. So where they're not eating, they might not even be drinking water. They're exercising, 4 or 5 hours a day, and they're very, very unwell from a physical point of view. They also want to be involved in the decision making, so not having decisions made for them, but being involved in that decision making. So making sure that you consult your patient as to what they want to do and where they're at. And they want consistency of care as well. So one of the major complaints is when people are bounced from different professionals or different services and needing that consistency. And that's where if you have your multidisciplinary team, you can get that consistency because there's that group working together. It's also important to have a good therapeutic relationship with your team. So that's coming from the patient's perspective. And trying to not comment on people's weight, whether they have an eating issue or not. It's one of the major things where patients will say, the doctor said, my weight's okay, I obviously don't have an eating disorder because my weight's all right. And like I said, sometimes you can have very, very severe presentations where people are actually in a healthy weight range. So trying not to comment about that. Also comments like, you're looking better, you're looking healthier. Often people interpret that as I look fatter than when you last saw me. So just be mindful of those things. Also having a think about, how much time you do have to work with a patient, and if you don't have the time, is it more appropriate to refer them to somebody else in your practice or somebody else that you know, or where you really encourage them to see a psychologist and dietitian who can do those longer things, and yours might just be the medical management of those particular clients. And around the medical management, it is around, getting their bloods done to see where they're at that way, getting their physical health checked, getting their bone density checked, so that you're just making sure that that person is functioning okay. Having a look as well, just very quickly, around stereotypes. Is there a lot of stereotypes around what somebody with an eating disorder looks like, or what they're doing? Majority of people that I see with an eating disorder don't look like the stereotypical person with an eating disorder. Often with eating disorders, we think about anorexia. We think about an emaciated teenager who's middle class and is fixated on her appearance. That's the stereotype. The reality is I see a lot of men, a lot of males who have anorexia nervosa and are severely unwell. I also see a lot of people who are middle-aged. I see people across socioeconomic areas. So really, really trying not to base what somebody looks like as to how psychiatrically well they may or may not be. And so trying to really think about the questions that you might be asking permission to ask certain questions, like, do you mind if we talk a little bit about your weight or about your body, so that the client or the patient has that control and can feel in control of what information they're sharing with you. As I mentioned, just in terms of assessment, I as a psychologist really rely on your assessment of their physical health. So, you know, is their blood work changing? Are they getting healthier? Are they getting worse? Where are they at in terms of bone density, in terms of hormones as well? So I see a lot of people, a lot of women who are wanting to fall pregnant and they can't because they have amenorrhea, or they're just physically not in a good place, or mentally they're not in a good place, and so they're likely to bring that eating disorder into pregnancy, into a child's early life as well. And with the eating disorder, Medicare rebates as well, that's a big thing. If a client fits the criteria for an eating disorder, being able to offer that 40-session rebate from Medicare. If you're not sure and you're working with a psychologist or dietitian, they can help. So I can provide that diagnosis for you, and then you can actually complete your Medicare compliance that you need so that that person can access those additional services. So essentials are trying not to judge from what somebody looks like or what somebody might be saying, to really empathise with the person's situation, to ask where the client's at, what they would like in terms of treatment. Have they sought treatment? Have they been to see a psychologist or a counsellor? Have they told their parents? Have they told their partners? And how can you assist with that? And also making sure that you set good goals with your patients, and your goals might be completely different to theirs as well. So working out where a person's at. And I can see if I've got my 5 minutes. No. Oh, right. Okay. I will. I'm almost finished. So just to finish off there with treatment, it really requires a team. That's the most important thing. Don't hold this on your own. Make sure that you're engaging the people in Canberra. There are dietitians, there are psychologists who are specialising in this area or interested in this area, and making sure you're utilising those people. Very, very briefly, and you can see this on the slides, there was a question before we had today just around what does the cognitive behavioural therapy look like when a psychologist is working with a client. And so I've just briefly listed there the different components, so they'll be on your slides at the end of the day, so you can have a little look through that. And that's the end of my presentation. So thank you. And happy to take questions after George has presented. Thank you.
Thank you, Vivian. And I have to say 5 gold stars to the eating disorders team. They've worked as a real team with doing their presentations for today. So they're obviously very good at teamwork. Okay, next we have Georgia Houston, who is an accredited dietitian, and she's also got an undergraduate degree in psychology. She works really hard in that healing people's relationship with food. Her passion stems from her own experience of being a teenager with an eating disorder, and she works privately with people, helping them to overcome their eating disorders. Thank you.
Tough acts to follow. I'm a little bit clammy and nervous, so forgive me. Hi guys, I'm Georgia. So I'm a dietitian in Canberra with my own private practice called GH Nutrition. And I specialise mainly with young women and men in eating disorders. I went to uni at UC and I did my undergrad in psychology at ANU. So this is my little office. I like to make it my safe haven for clients, not so clinical, it's more of a safe spot. And in my spare time, I like to do a food product line. So I created my own cereals and energy balls, which I do with my mum, best friend, little team around me. And that all stemmed from my fear of having breakfast. So it's a nice little story there. Okay, so what I'm going to do in my time slot is why eating disorders chose me. The eating disorder plan that GPs can recommend, blood work, what to look out for, a model that I use in my clinic called the RAVES model, what to do if a patient is not compliant with the dietitian's advice, and then referral details. So this is a not so glamorous photo that I don't often share, and that's me about 10 years ago. And I suffer from the disordered eating orthorexia, so that whole clean eating movement I took to the extreme, because as most people with eating disorders, I'm a bit of a perfectionist, and I like to do things 100% or not at all. So when I was 19, first year out of high school, I started to look on social media and started to eat a bit healthier. I started to take up running, cutting out chocolate, cutting out alcohol, cutting out carbs, all because I thought it was going to make me healthier and make me happier. Within a year, I got severely underweight and I lost about 10 kilos, and my parents sat me down one night and said, "We think you need help." And as a perfectionist, I hated that and I refused. And I remember still to this day crying, saying I do not want to go to hospital because that's where I thought I was going to go. So my mum the next day rang the Butterfly Foundation and said, "What do we do?" And we went to my family GP, God love him. He's been with my dad since he was a kid, but he had no idea. And I hated the word eating disorder. So that really stopped me from getting help for a long time because I was so ashamed. Then I started talking about it once I was getting help because I was realising I went to an all-girls school in Canberra that so many girls in my year were going through the same thing but silently. So once I started to get better, I started realising, okay, more needs to be done here because I'm not alone, and that's how I felt. I saw a dietitian in Canberra and she scared the crap out of me, told me to go eat an ice cream that night, and I hadn't eaten anything unhealthy in about 2 years, so I didn't go back and I got worse. Then I went to a dietitian in Sydney with my dad and I loved her, and I thought that's what I want to do because you just made me feel like I want to get better. I think a big difference with me is I wanted to get better because having an eating disorder is miserable. So that was my motivation. So now I go into girls' high schools and I talk about eating disorders and try and make not people feel like it's a bad thing. We need to get better. So this is an eating disorder plan, and I love this plan. It's quite new. It came out in November 2019, and it allows, instead of the mental health care plan, which is just for psychologists, 10 sessions, or a normal healthcare plan, which is only 5 sessions, it allows 20 sessions for your patients to see a dietitian and 40 sessions for a psychologist within 12 months. A lot of the time from GPs, I get a mental health plan and I can't do anything with that. That's just for the psychologist. So I really encourage you guys to have a look at the eating disorder plan if your patient fits the criteria, which I'll go into in a minute. Forms to complete to be eligible for the eating disorder plan. The item numbers are 90250 to 90257, and a longer appointment is needed. There is an eating disorder examination questionnaire to be filled out, and a score over 3 is an indicator for the eating disorder plan. And then there's also a GP care plan review template, which a dietitian doesn't need, but a psychologist does. In terms of communication, I like to spend my whole Fridays communicating to GPs. So it's a long process, but every Friday I will mainly send a lot of emails to Vivian as well, just updating the GPs and psychologists, psychiatrists on the updates of my clients that week. So dietitians only are required to report after the 1st and the 20th session, but I like to do it as often as needed. So might have cut off. For an eating disorder plan, there's a clinical diagnosis, which a psychologist or a GP psychiatrist can do, a global EDEQ score of 3 or higher, and characterised by the following conditions, such as rapid weight loss or frequent binge eating or inappropriate compensatory behaviours with 3 or more occurrences in the past week. And the patient has at least 2 of the following indicators below. And I thought it was very interesting, avoidant restrictive food intake disorder is not eligible for an eating disorder plan. And this is just an example of the EDEQ. So from a dietitian point of view, why I like to really focus on blood work is because there's a thing called a refeeding risk. And I remember at uni they said the one way you can kill a client is with refeeding risk. So I thought, okay, right, I need to memorise that. So this is most likely to develop in people with a BMI of under 14, which they should be hospitalised at this point anyway. And it's characterised by the occurrence of cardiac failure, delirium and death due to metabolic derangements that can occur during the refeeding of a malnourished individual. So it really results in a rapid reduction of already depleted electrolytes, phosphate, potassium and magnesium. And it's rare, but it can be avoided. So that's why I like to get blood work done weekly if they're very underweight or their blood work is abnormal. So indicators for admission to hospital based on refeeding risk for adults, Canberra Hospital guideline. A high risk is a BMI of under 16, extreme risk BMI under 14. Weight loss greater than 10% body weight within the last 3 to 6 months or over 1 kilo per week over several weeks. Little or no nutritional intake for greater than 5 days. Your blood pressure under 90, under 80, and then the list goes on. And then this is indicators for admission based on refeeding risk for children and adolescents. Heart rate under 50. I think there's, BMI under 14. Rapid or consistent weight loss greater than 1 kilo each week for 6 weeks or more. Hands up who's heard of the RAVES model in their practice. So this is a model that is created by an Australian dietitian called Shane Jeffries. And I love this model. It's a very simple step approach. So when I went to a dietitian, she said, eat an ice cream tonight. That's jumping to being spontaneous, and that's at the end of the model. And what you will not see from me is me handing out, unless they're severely underweight or needed, a meal plan at the first session, because they're not going to do that. If I can get them eating one more extra meal after my session, that's a huge win for me. So it's an acronym, and it provides a step-by-step process to help people develop a healthy relationship with food. And it stands for regularity, adequacy, variety, eating socially, and being spontaneous. It's sequential and complements the pace and progress of the patient, and it's best completed with a team, so the psychologist, GP, and myself. So the first step is regularity, and regularity, eating multiple times a day, is the foundation of healthy eating. At this stage, I don't care what the patient is eating. They can be eating fruit multiple times a day. Of course, that's not ideal or sometimes safe, but at the moment, I just want to get them increasing the amount of times they're eating their safe foods. The end goal of regularity is to eat 3 meals and 3 snacks a day. And I use this for people with anorexia, binge eating, because the regular eating helps to reduce grazing, prevent binge eating, improve metabolism, strengthen digestive muscles, improve bowel regularity, etc. For people that are really scared to be eating more and putting on weight, I always go on the thing that it's increasing your metabolism, and we try and find positives within that list of group there. The second step, so once they're eating regularly and they're not as scared to eat, we move on to adequacy, and that's when I look at what they're eating, and we look at the food groups and what their nutrition requirements are for their age and height, and it's optimal functioning. So this is where we get to a healthy weight range. This is where clients should get their period back, and their blood should be within a normal healthy range. This is really important because when, as talked about in that starvation syndrome, when our brain is properly renourished, then we can start thinking clearly. The third step is variety, the spice of life. So this step involves developing a positive relationship with food, and we start to tackle fear foods, good foods, bad foods. And it leads the way to more social eating. Before this step and before social eating, I don't care if my clients avoid social situations. I just need them eating at home, feeling safe multiple times during the day. I like to keep it very black and white, and these people are very black and white thinkers. And variety involves moving beyond safe foods and the notion of good and bad foods, and it allows food to become more interesting and enjoyable. A lot of my clients say they don't like certain foods, but once we can get them a bit more nourished, they begin to eat all the foods that they used to love. Then we have eating socially, and it's being able to go out, and we're getting back to normal pre-eating disorder behaviours. It can be very challenging for patients to go and eat out, as it involves other people preparing, cooking food, not knowing what's in the food. And then the last one is being spontaneous. So it's about having a more natural relationship with food. This is what we call intuitive eating, not thinking about food, eating when we're hungry, stopping when we're full, being flexible. One of the questions that was put forward was what to do if a patient isn't following the dietitian's advice. And what I would say to that, it's all case-based and very individualised. Offer other health professionals, offer other dietitians. As I said, I didn't connect with my first dietitian. I love my second dietitian. It's just who they feel comfortable with. You can go on find an APD, so an accredited practicing dietitian, on the DAA website, Dietitians Association Australia. You can type in Canberra and that gives you a list of dietitians and their contact details. What I would recommend from in the short sessions that you have with your patients is just to encourage one extra meal or snack. So say it's a safe food, I just need you eating one more time in the day. And using clinical judgment if you need weekly bloods, check up nurses, GP to monitor. If it is a child or a teen, it can be very difficult because when they come, they often have a lot of control. For example, I was eating totally separate to my whole family, which was heartbreaking for my family. I needed my parents to take back all of the control, and that means not choosing what's for dinner. That means parents coming into the school and sitting with the child, or the child going to a nurse or someone at the school to be monitored. It can be very time consuming and really draining for the whole family. And then I like to keep it simple. So instead of talking about calories, I like to do a plate model like that where it's a peace sign. So it's a third, a third, a third, an equal proportion of fruit and veg, protein, carbohydrates. And as I was a bit nervous, I fled through that.
So next we have Jess. While Jess is giving you a little show of what's on Health Pathways for Eating Disorders, if we could have your questions for the presenters, that'd be great.
The eating disorders page has had quite a lot of input. So the original and the clinical page was developed in conjunction with Sydney Children's eating disorder team, the Butterfly Foundation, and both the Southern New South Wales and ACT eating disorder coordinators have been involved. So be assured that you can have the information available if it's something that you don't often get. Red flags are designed to sort of prompt you what to look for in terms of probably should focus on those. So a lot of these presentations needs immediate treatment. So these are the people you're probably going to be referring to emergency department. So it's designed to stop there, like they need to go to ED. So a little bit of background information you can read in terms of about eating disorders, so the assessment is there to guide you in terms of what type of symptoms to ask for. There's questionnaires to remind you, taking a history, in terms of what kind of examinations you should do, investigations, and considering diagnoses. So the management, obviously a shared care model is important, which we've seen here today. Engagement being one of the priorities of treatment. So obviously if they're medically unstable or psychiatrically unstable, we need to refer these people to the emergency department. And there's just all the indicators for admission here, just to sort of remind you what to look out for, specifically around child and adolescents, as well, being a little bit different. And then sort of just some reminders about what to do with adolescents and children, and moving on to the forms of treatment. So the eating disorder referral is always up there as well. So, and this is what we talked about in both ACT and Southern New South Wales. So obviously if they're medically unstable, refer them to emergency department. There's advice, you can call the admitting officers, and then we talked about the eating disorders programs and how to contact the service. And referral forms are in there, what kind of information is required. So have a look about what sort of tests you need to order, which is a really good reminder. Often you sort of forget little things, so just checking there, make sure you've got the required information, what the criteria is, does my patient meet the criteria, and the link to the referral form. So that's all there. So it should be all there available for you. Obviously, you can provide feedback if anything changes. It's designed for GPs, and we've also just a reminder that we do cover Southern New South Wales as well. So these are all the services available, but we also cover the private services. So don't forget about if your patient has funds to go privately, then I'll direct them there as well. The other one I wanted to quickly highlight as well was the GP colleague referral page. While I've got you all here, we're trying to get a network of GPs who either have like a special skill or an interest, and they would be happy to see patients for specific things. So whether it's minor procedures, transgender health, we would really like to, rather than referring them into the hospital system, if we can refer them to a colleague, then that would be ideal. So there are some forms at the back if you'd like to nominate yourself, otherwise your colleagues are all up there, and a specific request from the ACT Women's Health Service that if anyone would like to take on some women for long-term GP care, then please let them know they're available. Put your hands up. So there you go.
So thank you very much for those presentations, they were terrific. Our first question is for Georgia. Can the SCOF questionnaire be used in the eating disorders plan?
Sorry, I've never heard of the SCOF.
Okay, so the SCOF questionnaire, oh, I've got it here. Well, I won't do that. It's a quick screening tool for GPs, and it sounds like it's not.
Yeah, no, it's a screening tool. The criteria for the eating disorder care plan is, it does say specifically diagnosis of anorexia, and if not anorexia, it's got to have bulimia or binge eating, and two of the criteria, and an EDEQ score is one of those criteria. So yeah, unfortunately SCOF does not suffice for that.
Okay, so in terms of creating a team, finding those dietitians and psychologists that have a special interest, clearly there's the Clinical Psychologists Australia webpage, and you can put in eating disorders, the same for dietitians. Are there any other, kind of established networks, because clearly you guys all talk to each other, and how do we as GPs tap into those private little networks?
Well, for psychologists, you can go to the Australian Psychological Society website and find psychologists in the area and their area of interest. So that's a really good way of doing it. Also, we have an organisation called the Mental Health Professionals Network. And anybody can be a member of that, so any health professionals, and that's how the three of us know each other. So we have the Mental Health Professionals Network in ACT, which is specific for eating disorders. So it's a link, if you're part of that, where you get information around, okay, who in Canberra are the eating disorder people who are either interested in it or specialise in it. And GPs can be part of that. And up until COVID, we used to have regular meetings, and so we'd all see each other, have case discussions, talk about tricky patients that we have. So I'd encourage you to become members of those groups, because then through that you can find the professionals, whether it's in Canberra or anywhere around Australia. And it also has groups for, schizophrenia, other mental health issues.
Terrific, thank you.
In terms of other databases as well that are specific for eating disorders, I think there was a link on HealthPathways. The Inside Out Institute, which is a New South Wales government page, has a directory of people who have an interest in working with eating disorders. And I believe the Butterfly Foundation also have a database, and to be on their database, my understanding is that you have to the clinician has to answer questions and demonstrate an understanding of eating disorders. You can't just say, yes, I'm interested in eating disorders to get referrals. So there are other options as well.
There we go. And the Inside Out also has e-learning for us.
Yes, and I was also just going to say the Butterfly Foundation, which is the national eating disorder service, has heaps of resources. You can actually, as a GP, they have a separate section which is actually for GPs, which gives you lots of information around, what do you do, what do you need to check, questions to ask, all that. So the Butterfly Foundation has information also for carers and patients. So again, you can encourage your patients to go to the Butterfly Foundation as well to get resources, and so that's another way.
The other thing is that we do have on HealthPathways a psychologist referral page. It does need more population, so if there is the information we've been provided, but if you're using those pages and you're aware of some service that's not there, use the little feedback tab, and the lovely Sharon will update the thing. Also, if you see a mistake on HealthPathways, or is there something that you think's missing, we're really open to feedback. It's a really live resource, and we really want it to reflect what you guys need and want, and have it be as accurate as possible. Okay, what strategies would you have where parents are concerned but the client does not at all appear motivated?
That happens all the time. So majority of clients that I see who are either young people, so children, adolescents, yes, the parents have recognised as an issue and they've come to get some help, and 9 times out of 10, the child is refusing help, and it causes the family, as I think Georgia was saying, enormous distress. And I think that's one of the worst things about working with families where there's an eating disorder present, is that there's a lot of family conflict that happens, a lot of distress. Because if you think about it, if mum or dad, you've got, say, a 15-year-old daughter that is severely underweight, is very unwell, and you're having to take over all of the feeding, make sure that she's eating at school, make sure that she's having all her snacks, that she's eating fair foods and all that. And if you don't want to do that and you refuse to do that, it creates enormous distress within the family. And so you will see parents at their wits' end because they don't know what to do and they don't know how to make their child eat. So it is one of those really, really distressing. And that's, again, when we come back to working with the team, because then you can sort of talk about that and you can talk about the difficulties that you're having and what you might do. And it does have to be sometimes with parents where you have to just tell them what they have to do. Like, you have to make your child eat and you have to find a way to do that.
So at the Eating Disorders Program, the therapy that we offer for young people in the first line is family-based therapy, which is basically what Georgia described as she needed her parents to provide her with meals and support her to eat. it is easier said than done, but I guess I just want to share a beautiful experience I had with a family that I'm working with who, prior to coming to the eating disorders program, they were seeing a private psychologist. The young person was seeing them individually. They only said good things about the psychologist. They said the psychologist was in tune and wonderful, but what the parents needed was the permission to be the ones to sort of step in and take responsibility of sort of those choices about food and supporting their young person to eat, and that's when they started to see change and recovery in their person. And for so many young people or anyone with an eating disorder, it doesn't matter what age, like having to choose what to eat is actually really distressing in itself. So having that decision taken away, like they don't have to make that decision, it can take away some of the guilt. It can be so helpful. The challenge is supporting the parents to do it in to remain calm and remain supportive. Again, easier said than done. I think again there might be links on the HealthPathways to websites called Maudsley Parents and some other resources as well, which are really about the family-based therapy. And given the waiting times at the eating disorders program, we often refer parents to those websites to be like, even if you can start to read what this involves, what some of the principles are, and start to think about what can you start to do now. But yeah, it is stock standard that young people are there under duress from their parents.
So leading on for that, mandatory reporting. You know, we're quite often, in a way, treating against people's will, and we're being invasive, we're weighing, and we're getting weekly blood tests, and I know we're doing that to keep people safe, but we're treating them against their will. So treatment disorders and mandatory reporting, how do you... I mean, given no one's going to want any of that stuff to happen, how do we decide when we really need to?
I think I find with young people, it is more about working with the parents. So in terms of mandatory reporting, are we talking about care and protection issues or...?
Well, not treatment against will.
Okay.
Mandatory treatment under a mental health act.
I've got to say, in the 11 years I've been at eating disorders program, there's been less than a handful of people on a treatment order. More often, and that's because we're an outpatient voluntary service. So I don't want to sort of sit here as sort of the expert on treatment orders. A lot of the time it might be someone gets taken to hospital under an emergency action, and then once they're in hospital, the psychiatrist there may sort of extend that order. But yeah, often from my experience in the first instance, it has been an emergency action that's kind of got them to hospital.
Yes, I'm just going to say, I mean, it is one of those really distressing things, I think, from a GP's point of view, is you will have patients who are really, really unwell and they desperately need to be in hospital and maybe go through refeeding and what have you, and they refuse to go, and then it is a really, really tricky area, because, I mean, I've worked with a lot of people where the GP has sent them to emergency and then they've been sent home. And that's really, really disappointing and distressing for everybody, because you so desperately want that person to get the medical attention. And it does have to be the case where medically they really need to be compromised in order to get them admitted. And that's quite a tricky thing, which is why, you know, monitoring things like blood and cardiac and, you know, their general sort of physical health. And sometimes it is the case where you have to wait till someone is really, really, really unwell till they can actually get a hospital admission.
So, and just looking, there's the link to the involuntary treatment and eating disorders on the Inside Out website, and there's the processes in ACT and New South Wales on the eating disorders page. Okay, what about when eating disorders people are also on treatments for, say, depression? Do we have to adjust those medicines? Is there any special concerns? No.
Eating disorders are very strongly comorbid with depression and anxiety. You get a lot of obsessive compulsive disorder. You get autism spectrum disorder as well. So quite often, you're dealing with patients who are quite complex in terms of their needs, and yes, usually I say if medication is required, that engaging a psychiatrist to look at that, because it can be a bit tricky if people have sort of multiple diagnoses.
Right, and I'm just looking at the NEDC guide, so that it's looking at pharmacy and eating disorders. And what they're going through is the abused substances and then the pharmacokinetics.
And that's something that's quite common as well, abusing substances. So, maybe smoking because there's that perception they'll lose weight, or drinking because they just don't want to think about it anymore. So you often have those issues as well.
Okay, thank you very much, guys. So thank you everyone for coming today. We've done that. I just need to remind you that if you don't do evaluation, you will not get CPD points from the RACGP. That's their rules, not ours. You will be sent an email with a link to do a SurveyMonkey to evaluate the event. If you're a non-RACGP, in fact, if you are an RACGP member, we will send a certificate of attendance to everyone so that you can use it as documentation for whatever your program is. But we cannot allocate RACGP points unless we have your surname, your number, and your evaluation. I'd like to thank everyone for coming today, our speakers, also the HealthPathways team, who has worked really, really hard to get this event on today, with a couple of last-minute problems that they've mounted very well. I'd ask if you can all return your name badges to the front. We like to reuse them for the planet. Thank you very much.